Welcome to Final BDS Made Easy. Anterior crowns in pediatric dentistry is one of the important 5 marker questions in the subject of pediatric and preventive dentistry for your final year exams. This answer is prepared from Nikhil Marwah. Restoration of severely decayed primary anterior teeth is a significant challenge in pediatric dentistry, primarily due to the high aesthetic demands from parents. Dental caries, especially early childhood caries, often leads to severe damage or complete loss of crown structure in primary teeth. This condition can affect the maxillary central incisors, lateral incisors, and the maxillary and mandibular first primary molars, with the maxillary primary incisors being the most affected. Now coming to the classification, intracoronal restoration can be direct or indirect. Full coronal restorations can be luted, that is stainless steel with facings, Cheng crowns, Kinder crowns, New Smile, Dura crowns, Vita-Biter, Pedopearls, and Ceromo base metal childers. And bonded full coronal restorations are polycarbonate strip crowns, Petro jacket, New Millennium, and Glastec, which are further classified as crown build-up restoration of severely decayed tooth, which are again classified into direct and indirect. Direct ones are resin composite short post technique and orthodontic wires shaped as Greek alphabets like alpha, omega, theta used as intracanal retainers. And indirect ones are indirect composite resin crowns reinforced with a fiberglass post and biological posts and crowns. Starting with the anterior stainless steel crowns, they are durable, economical, reliable, fracture-proof, wear-resistant, and firmly attached until exfoliation. Disadvantages are that they are poor in aesthetics due to metallic appearance and difficulty in removal. Facial cutout stainless steel crowns. These are indicated for maxillary canines where strength is prioritized over aesthetics. Technique is labial portion of the stainless steel crown is removed and composite is placed in the labial fenestration, offering improved aesthetics while maintaining the strength. Let's see the technique. First step is select a crown. Then start with proximal reduction, creating a chamfer. Minimal palatal and buccal reduction has to be done as these provide retentive undercuts. Check for fit and reduce the crown wherever needed. Contouring and crimping is done with pliers. Cementation of crown. Create a window on the facial aspect by cutting the crown and fill this using composite resin. Are the pre-veneered stainless steel crowns. Advantages are that they are aesthetic, full coverage, easy to place and satisfactory for both child and parents. Types are Cheng crowns, Kinder crowns, New Smile, Vita-Biter, Pedo crowns and Dura crowns. Disadvantages are its limited crimpability, aggressive tooth reduction required and high cost. Cheng crowns are stainless steel crowns with composite facings. They are stain resistant and available in various sizes and can undergo heat sterilization. Disadvantages are potential veneer fractures which can occur during crimping and its high cost. Next are Kinder crowns. Features are natural shades. They are strong due to incisor lock technology and available in two shades, that is Pedo 1 and Pedo 2, and optimal union of bonding and mechanical retention. Next are the bonded crowns, which are the polycarbonate crowns. They are aesthetic, easy to trim, stable dimensionally, and unaffected by acids and alcohol. Disadvantages are its poor abrasion resistance and they are contraindicated in cases of bruxism and deep bite. Now let's look at the technique for placement of polycarbonate crowns. First step is correct size crown is selected by measuring the mesodistal width at the level of the contact point of the prepared tooth or by measuring the width of the contralateral tooth in the same arch. Cervical crown margin is trimmed to the required contour with crown scissors or by grinding with a trimming burr or stone. The crown is then lined with acrylic or composite material. If cold cure acrylic is to be used, the material should be poured into the crown after mixing, and once the dough stage is reached, it is heated over the preparation. Prior to seating the crown, the preparation and surrounding gingiva should be lubricated with water or saliva. As the acrylic starts to set, the crown should be removed from the preparation and reseated a number of times. Removal of the crown during polymerization of the acrylic resin helps to dissipate heat buildup from the exothermic reaction and prevent locking into the undercuts. Lining a polycarbonate crown will ensure good marginal adaptation to the preparation. Cold cure acrylics chemically bond with polycarbonate crowns. Composite materials need some retention by mechanically roughening the inside crown surface. A chemical bond to composite can be obtained by priming the fitting surface of the polycarbonate with methyl methacrylate liquid. After the lining material has set, the crown is removed from the tooth and margins carefully trimmed and finished. It is important that an accurate fit is obtained at the preparation margin to maintain gingival health. After checking the fit and occlusion, the polycarbonate crown should be cemented using proprietary temporary luting cement and the excess should be removed. What are these strip crowns? These are celluloid crown forms filled with composite. They are easy to place and remove, less time consuming, superior aesthetic quality and matches with natural dentition and large size selection. Technique is, first step is tooth should be anesthetized and isolated. Next is size selection of celluloid crown formed by measuring mesodistal dimension of the space available. Removal of caries using small round bore. Next is tooth preparation, only proximal slices are made. Then shade selection of composite. Then trimming of celluloid crowns using curved scissors. Then trying of trimmed crowns fitted on tooth. Length and cervical fit should be checked. Vent holes in the crown for escape of air and excess material. Acid etching of the tooth. Composite filled celluloid crown placed on the tooth and excess is removed. Then curing is done. Excavator or probe is used to insert beneath the crown and crown form is stripped off. Final adjustment includes smoothing and polishing. What are the shell crowns where indirect approach is used? Using custom-made composite shells, it reduces the chairside time and ensures better precision and aesthetic outcome. The technique for placement is after caries excavation, full arch impressions of the maxilla and mandible should be made with the cast poured and set. Double coating of the separating media is to be applied, which acts as a spacer for luting resin during the cementation process. Composite buildup should be done on the cast in harmonious relation to the mandibular anterior teeth. As it forms a complete shell-like structure over the affected teeth, it is called as composite shell crown. After completion of indirect restoration on all the teeth, the shell crowns were finished and polished. A silicone-based positioner was fabricated. The shell crowns were then carefully detached from the cast. The silicone positioner is used to check intraorally for accurate fit, initially without the shell crowns. The teeth to be restored are etched, rinsed, dried, followed by application of bonding agent and curing. The shell crowns were filled with flowable luting resin, placed in the positioner and transferred intraorally. Excess luting resin was removed with an applicator tip moistened with bonding agent. Light curing is recommended to be done eventually over each shell crown. Positioner is then removed gently and additional curing of the shell crown is done from the lingual aspect to ensure complete polymerization. And last step is finishing and polishing of the shell crowns. Recent developments include the pedo jacket. It has tooth-colored copolyester material filled with resin. It is left on tooth after polymerization and it does not split, stain or crack. Disadvantage is its limited size availability. Next are new millennium crowns. They are made of laboratory enhanced composite resin or zirconia with promising aesthetic and functional qualities, though lacking long-term studies. Next are art class crowns. These are patented for pediatric usage. They have high inorganic filler content. They are color stable, plaque resistant, and the flexural strength is higher than porcelain, 50% higher than porcelain. They are easily adjustable or repairable, and they combine aesthetics of porcelain with the bondability of composite. Thank you for watching. If you appreciate this video, do hit the like button, share it with your friends, and please subscribe to my YouTube channel. Stay tuned for more such videos.